And please allow me now to invite our first speaker for today's program, Dr. John Teo. Dr. John Teo is from Lita Square Women and Specialist Clinic from Malaysia. Dr. John is the editor and lead contributor to the long-acting reversible contraceptive guidelines for Malaysia and also the chairperson of the Family Planning Subcommittee of the OGSM. Today, he will be discussing the topic, current issues and the paradigm shift in sexual and reproductive health. Dr. John Teo, please.
Thank you very much, Dr. Huang, for the kind introduction. It's my great privilege and honor to be here today to share with all of you this presentation. So what I plan to do is to actually give everybody an overview of unintended pregnancy, and of course share a bit about our common practice and how we can actually change a bit of what we do so that we can provide better care and decrease the risk of unintended pregnancy. And finally, what I will do is to share a bit on COVID as well, because we've been battling it for the past 18 months and it doesn't seem to go away. And of course, SRH is critically important in this time. Right, so just a bit of overview here. If you look at unintended pregnancy among women with unmet needs for modern contraception, and this was 2017, I don't think the figures has changed much. You will see that 84% of all unintended pregnancy came from unmet needs, and that 74% of them actually do not use any method, and 10% of them use traditional method. So a huge majority of women who have got unintended pregnancy basically do not use contraception. The question is, of course, why? Why is this a problem? And it's particularly a problem in developing region. These are the four main reasons. 26% fear of side effects, worry about the health risk, infrequent sex, breastfeeding and postpartum amenorrhea. And a lot of them think that, for example, if I just deliver, then the risk of pregnancy is low. That is not true. And contrary to popular belief, it is actually only 5% who have got no access. So meaning to say that a lot of women do have access to contraception. The problem is, of course, to get them to go on contraception. Yeah. And if you look at this, this is a graphical representation of it. And you can see that the prevalence of married women, this is a reproductive age group, the key reasons for non-use, right? And 2006 to 2013, you can see that infrequent or no sex is among the leading reasons, right? Next, we'll have worry about side effects, health risks, opposition by partner, and postpartum amenorrhea breastfeeding. And again, you see lack of access and lack of knowledge is way down the list, right? So most women know about it, right? I think this is a big problem here, which is infrequent and no sex. And many women then believe that, you know, because of that, the risk of unintended pregnancy is very low. In fact, it is still as high. And a lot of the time, unintended pregnancy occur because of those reasons, right? Okay. So now just going to share a bit about all the things that we normally do and how we can look at it in a different perspective, right? So this is a graph of a diagram from the CDC telling us the effectiveness of family planning methods. And you can see from the top line here, which is implant, IUD, sterilization, male and female, are one of the most effective methods, and they have got less than 1 pregnancy per 100 women in a year, right? So moderately effective would be injectable, pill, patch, ring, diaphragm, for example, which is 6 to 12 pregnancy per 100 women in a year. And of course, they are moderately effective, not because the method is not effective, but because they are patient dependent. And that's the problem. And of course, patient can forget, women can forget the pill, you know, turn up late for injection, so on and so forth, right? And of course, the low effectiveness are the male condoms, female condoms, so on and so forth. So now, one of the way we can actually increase or rather decrease the risk of unintended pregnancy is to try to advocate for a 24/4 regimen, which is more forgiving than the 21/7 regimen. We know that pill is highly dependent on women not forgetting, right? So during the 7-day interval, if they forget, for example, then of course you forget for 1 day or more, then the risk of breakthrough ovulation will occur. So if we advocate for a shorter pill-free interval, then in fact, it will be much more effective, right? And less likely to have breakthrough ovulation. In fact, John Gilbert, who is, of course, most of you know, who is a very eminent gynecologist in UK in sexual reproductive health, and Anne McGregor here has written in the BMJ, and this is the title, the 7-day contraceptive hormone-free interval should be consigned to history. And indeed, that should be the case. We should now, you know, not regularly tell women to use the 7-day interval, but in fact, shorter interval or even no interval. That way, we can actually decrease the chance of breakthrough ovulation and of course, the risk of unintended pregnancy. Now, in January 2019, FRHH guideline tells us about this tailored regime. This updated in November 2020, just recently. And basically, there is no health benefit from the 7-day pill-free interval. We all know that the reason why you know, you have this pill-free interval is to regulate the period, right? The main contraceptive effect is more from the progesterone component rather than the estrogen component. So if you look at the standard 7-day pill-free interval, they are associated with more hypothalamic pituitary ovarian activity than a shortened 3 or 4 days. So if you got a shorter pill-free interval, it will reduce the risk of pregnancy and escape ovulation, is what I was saying. So we can do it in various ways. We can shorten it to 4 days, like what I was mentioning before, right? Or we can have extended use, you know, tricycling, which is 84 active pill, and then 4 days as well. Or, of course, another way is a flexible extended, which means 4 days of pill-free interval whenever there's breakthrough bleeding. So the women can just continue the pill all the time until there's a breakthrough bleeding. Then they have that 4-day interval and then start again, right? Or in fact, continuous, that means never break, right? Of course, that's sometimes not so comfortable because then after a while, you will have this breakthrough bleeding and you cannot predict when you have this breakthrough bleeding. So practically, it's either the shortened one, the tricycling would be more practical for women, or sometimes flexible extended. Now, of course, the question is safety. Cardiovascular, metabolic, hemostatic, and endometrial safety, there's no difference between the standard or tailored regime. So basically, that's the way to go. If we can try to do that, there's a much decreased risk of unintended pregnancy, right? Moving on, I just want to cover a bit about emergency contraception. We're also familiar, but yet it's been used very infrequently, and especially copper IUCD. You know, very few, if you look at your many practices, very few people actually put emergency copper IUCD, although it's the most effective EC and should be offered to all women requiring EC. But yet, I think most women who go for EC would either take the pill or whatever, but rather very rarely be offered copper IUCD. And why copper IUCD should be offered to all women is that it can be inserted 5 days after the first UPSI in a cycle, which we know, or this is where the beauty of it, or within the 5 days of the earliest estimated date of ovulation, whichever is the latter. So if you got a 28-day cycle, you can insert up to day 19. So that is a critical advantage with copper IUCD, whereas the pill, you know, more than 5 days with EC, we cannot give already. But copper IUCD, you can give up to even day 19. So there's a huge time that you can cover. And it's so critical that women are offered this, because if they're not offered this, then the next thing that occurs is unintended pregnancy and its associated complication. Ulipristal acetate. If we can't offer IUCD, then we can offer uripristal acetate. It's effective up to 120 hours post UPSI. And it's a bit more effective than levonorgestrel EC. And the reason why it's a bit more effective is because I think if we go back to our medical student days, you know, before the LH search, there's LH search before ovulation. So before the LH search or during the LH search, the LNG-EC doesn't work so well. Whereas the uripristal acetate still work. Both act to delay ovulation rather than actually prevent it. But uripristal acetate is better at doing that, right? And just a note to say that levonorgestrel is licensed up to 72 hours post UPSI, and is ineffective if after 96 hours. So this is a complex diagram by FHRH, and I don't wish to go through the whole diagram, but just to point out that when you look at EC, right, emergency contraction, and that if a woman have got UPSI less than 120 hours, since less than 120 hours, you can see that, you know, the diagram all the way leads to copper IUCD and copper IUCD and copper IUCD and copper IUCD. So basically, it should always be the first choice if possible. Now, of course, it's not always possible because they may not have access. IUCD is not available. Doctor is not there. Then, of course, we can offer emergency pill. And if you offer emergency pill, if IUCD is not available, then usually, if possible, we try to offer uripristal acetate first for the reasons that I have mentioned. And of course, if not suitable, or if the woman unable to access uripristal acetate, then the next one would be the most commonly used EC, which is the levonorgestrel EC. Right. And just a bit about quick start contraception. Again, it's something that perhaps we should advocate as much as possible. Additionally, a lot of women who then come to request for contraception are always then, you know, asked to come back if they come on the wrong day, for example, you know, if it's more than day 1 to day 5. But quick start contraception advocates that we immediate initiation of contraceptive method at a time the woman requests rather than waiting for the next period. And that's basically that we try to provide as immediate contraception as possible to reduce her risk of unplanned pregnancy. We know that many times when we ask women to come back, you know, the next thing that happened would be a UPT positive. Yeah. So, and of course, it prevented women from forgetting the info on correct use and all those things because we counsel there and then. The worry, and it's particularly, I think, applicable now because of the cost of, you know, returning to clinics and whatever, and of course the risk of, you know, you want decreased face-to-face consultation. Yeah. So we can offer quick start contraception. We can offer quick start contraception if at any time during the period, if we are reasonably sure the woman is not pregnant, because that's always the worry that if they come later than day 5, then they may be pregnant, right? So if she has got no signs or symptoms of pregnancy and meets any of the following criteria, she has not had intercourse, for example, have been correctly using a reliable method of contraception, is within the first 7 days after a normal menses, or within 4 days postpartum for non-lactating women. So as long as she satisfies any of these criteria, then we can say that she is not pregnant, and we can immediately start the contraception for her. So that's a quick start contraception. Of course, for all hormonal contraception, it takes 7 days to work, right? So even if we start today, we will have to get the women to have the 7 days precaution, extra precaution of abstinence or using barrier contraception. Okay. Now, the question is, of course, can you combine EC and quick start? And yes, of course, you can do that, right? So if we use levonorgestrel EC, then you can actually quick start them straight away with the pill, for example. or other types of hormonal contraception. If you use ulipristal acetate, then it has to be 5 days later. And of course, we know the reason why is because ulipristal acetate belong to this selective progesterone receptor modulator. So it's basically an anti-progesterone, right? So then if we then give a combined pill and you start it straight away, so you've got the progesterone as well, and it may decrease the effectiveness of ulipristal acetate. So that's why you have to start it 5 days later. But that's different for women who are already on the pill, for example. If they've been taking the pill and they just miss 2 pills and they need EC and you give ulipristal acetate, then you can start immediately. So that's something new, right? As versus a naive user where they never used the pill before, then you can start, you then have to delay starting the pill 5 days later, right? And of course, we have to follow up with UPT about 21 days later, just to make sure that they are not pregnant. Yeah. Okay. Now, just the last 5 to 10 minutes of the presentation, I move on to COVID, and we know that all of us has been battling COVID for the last 18 months, and this is the impact of COVID on family planning 1 year old. This is from the UNFPA technical report, and the analysis from 115 low and middle income country estimated 12 million may have been unable to access family planning services. That actually resulted in about 1.4 million unintended pregnancy. And of course, we know that the main barriers are social distancing, lockdown, all those things. They cannot go and have their contraception. Some of the contraception clinics are actually closed down, supply chain disruption, so on and so forth. And I think this pandemic has put SRH about 5 years back, with all the progress, we've actually moved about 4 to 5 years back. And I think we have to really push up these services as soon as possible, right? This is again from the UNFPA report in Malaysia, published on the 4th of August 2021, and it's the 500 days of lockdown and the impact on Malaysia's women and girls. And the key issue is that access to life and essential SRH services, including family planning services, are seriously curtailed. And one of the main points is that during the lockdown, a lot of SRH services are actually shut down or decreased, and they are not considered essential service. And I think this is the main point that we have to push, that indeed SRH is essential service and life-saving service. And they should not be shut down, or neither should their service be decreased. Lockdown, economic disruption also, of course, greatly increase the gender-based violence, and we have to be careful about that, and we have to take cognizance of those facts. And the impact is worse on women who are the most vulnerable. They're living in poverty, they're living in the interior, the remote region, and even the urban poor, right? They feel the impact the most. Yeah. So as I said, there is an urgent need to declare SRHH as essential service to facilitate and expedite care. We need to empower and increase resources for NGOs to reach all of them. And we need more guidelines come out for SRHR pandemic guidelines for doctors, nurses, and healthcare workers, right? Because many just use their own judgment and deny care or decrease care, and that's a big problem. We need to ramp up telemedicine consult and access. And above all, we need multi-sectoral, logical, reasonable, coherent intervention, and SRH policies taking into account the lived reality of women and girls impacted by the pandemic. And every day, women and girls and families are impacted by this pandemic. Sorry. Right. And just finally, the last 2 minutes, this is the FHRH guidance on SRHK during the pandemic. Of course, 2 key points is that one is avoiding unnecessary face-to-face contact for contraception. So remote consultation and telemedicine is key to it. Maintaining essential contraceptive service. We have to have remote assessment of EC priorities, provision of new and ongoing contraception, and of course, post-pregnancy contraception is indeed very, very important, right? If you look at lactational amenorrhea and postpartum contraception, those who are fully breastfeeding, amenorrhea, and first 6 months, we used to rely a lot on this and said that you don't need contraception. But the RCOG, FHRH, the Royal College of Midwife guidance in February 2021 says that commence additional contraception as soon as possible after birth, as COVID restriction may affect access to other methods. And that's true, you know, and we can't rely fully on this because any of these factors of fully breastfeeding, amenorrhea, or first 6 months will just go off at any time, right? And so it does not specify those criteria anymore. Finally, the FHRH statement on the use of COC and during the COVID, those who are very ill with COVID-19, of course, you know, then you stop the COC. Those who have got mild as asymptomatic symptom, if we're worried about the DVT list, we can consider changing to POP. Those who may be exposed to COVID-19, for example, if worried about thrombosis risk, again, we can consider change to POP. But it's important, and this we must emphasize, it's important not to stop the COC abruptly for those with mild symptoms or those who are worried, because the risk of unintended pregnancy and the DVT risk and things like that will be much, much more compared to actually just ongoing COC. And those going for vaccination certainly continue the COC regardless of which time. Yeah. And just a final note on the use of COC and AZ, because we know that there is a higher risk of thrombosis with AZ. So the question is, should COC be stopped for those going for vaccination? The recommendation is to continue. The stopping may not reduce the risk because you stop immediately prior to vaccination. It may not reduce the risk as the risk may persist for some time. And when you stop, you expose those women to unplanned pregnancy, and the risk is even higher of thrombosis, as I said, if there's no other bridging contraction, unless we can actually put them on POP, right? And importantly, there's no data on whether current or recent COC users have increased risk of the very small specific rare type of venous thrombosis with thrombocytopenia associated with AZ vaccine. So the mechanism seems to be different. You know, the COC related DVT and the AZ related DVT, thrombosis and thrombocytopenia seems to be different. So there is no additive effect. Even saying that, say in Malaysia, for example, this may not be practically may not be much of a problem, because as we know, the main vaccine that Malaysia use are Pfizer and Sinovac, and there's only a small proportion that use AZ. So thank you very much for your attention, and I hope that helps a bit in terms of sharing the knowledge.
Thank you, Dr. John. That was very, very insightful, especially the part on COVID-19 and how it's relevant to us as doctors, you know, to use the family planning very wisely. You know, there have been a number of questions that's out now, and I really hope that you could enlighten us with your wisdom as well. So one question from the participant is, what is the risk of ectopic pregnancy for IUCD when it's used as emergency contraception? I think in the same vein, you know, what is even the risk of pelvic inflammatory disease you would advise on the risk when you use IUCD as emergency contraception?
Right. Okay. It's the same whether you use IUCD as emergency contraception or use IUCD in a regular use. The risk of ectopic is the same. I think I need to emphasize that IUCD do not lead to ectopic pregnancy. In fact, if you look at the absolute figure, IUCD users have got lower chance of ectopic pregnancy as versus non-IUCD users. But when you are pregnant with a IUCD, then the proportion of ectopic pregnancy increase compared to intrauterine pregnancy, because the IUCD tends to be less effective at preventing ectopic pregnancy as versus intrauterine. So I think that's something that we need to clear about. So there is really not much worry. In fact, if you look at the whole data, actually IUCD risk increase. So, and of course, if you can prevent the pregnancy, ectopic risk increase. And if you can prevent the pregnancy, then of course, the risk of any pregnancy, whether intrauterine ectopic, decrease as well. And on the same note, when you talk about pelvic inflammatory disease, again, it is not the IUCD that caused the pelvic inflammatory disease, but it is actually men that cause it, isn't it? Because it is actually a sexually transmitted disease. And you got chlamydia and gonorrhea there, and it's a sexually transmitted disease. So the risk of pelvic inflammatory disease with IUCD insertion is purely dependent on the risk profile of the sexual history, and the STD risk, rather than the IUCD per se. So IUCD per se do not actually increase it.
Right. Thank you, Dr. John. That was very, very insightful. The next question is, one of the participants also asked, how long will the breakthrough bleeding be expected using the 24/4 regime?
Right. Usually 24/4 because the pill-free interval is shorter. So because it's shorter, then during the pill-free interval, you have got shorter and lighter breakthrough bleeding. And of course, if you keep on doing that for a few months, about 20, 30, 40% of women will have sometimes no period, which is okay as well, as long as they are not pregnant. So as long as they do not forget the pill, then that is okay. But they need to be reassured, because otherwise they would think that, every month got no period and whether I'm pregnant or not. So that's a practical issue associated with this 24/4. But it is much, much, better compared to a 21/7.
Right. That's very helpful. So the other question that some person was concerned about, when in women with irregular periods and they wanted to use COCP as contraception, when will you start the pill? Can you immediately start if the UPT is negative?
Right. So it depends on the reason for starting. So if you said just for irregular period, for example, abnormal uterine bleeding, right? You can start straight away, or that means quick start, or you can start during the day 1 to day 5. That's purely to control the cycle. But the only problem is that if you start beyond the day 1 to day 5, sometimes you may take 1 or 2 months or 2 to 3 months to actually control the cycle. So it takes a bit of time. But if you talk about contraceptive needs and contraceptive objective, then certainly if possible, we try to start as soon as possible. And that's where the quick start come in. But of course, if they need both, that's mean to control as well as to start for contraceptive needs, then of course, immediately, if at all possible, as long as we are reasonably sure women is not pregnant. But we have to warn them that the next few months, we may take time to actually control the period.
Right. And I think there are so many questions coming in.
Right.
Everybody is very interested about the topic as well. Right. So let me ask this very interesting question. So any recommendation on the contraception for post-COVID patient who is postpartum, especially those of stage 3 and above? Is the risk for thrombosis even higher after starting the contraception?
Right. Okay. If you talk about postpartum, then of course, postpartum, there is a higher risk of DVT. And we know that in the first 6 weeks of postpartum, there's a higher risk of DVT. So the usage of any hormonal contraception would be dependent on the DVT risk. So for example, if we use the COC, for example, and the first 6 weeks, of course, the high DVT risk. And then after 6 weeks to 6 months, because they may be breastfeeding, so the COC may not be that suitable, but POP is not a problem. Now, the question is that if they got COVID, then they may got higher risk of DVT as well. Should we use hormonal contraception? And of course, you got to the 2 groups here, which is the progesterone only or the combined. The combined, of course, you should only use when we are clear that the DVT risk is down to normal. Yeah. And of course, that has to have the clinician to assess whether it's down to normal before we can start using the combined. But certainly using the progesterone only contraception, you can start earlier because there is no much relationship between the progesterone component to the DVT risk. Or of course, we can also consider non-hormonal contraception, like the copper IUCD or so on and so forth. Yeah.
Right. So there are more questions coming up. So Dr. John, let's move on.
Okay.
Right. So there's some concerns from the participants as well on how young can you start, an adolescent on COCP, and if the young adolescent is overweight or obese, is the risk of VT, as high as someone who is older?
Right. Okay. Age is not a barrier. Age is not a barrier to using COC. So you can use at any time as long as you think that the DVT risk is not super high. Now, of course, the guideline is follow the WHO MEC, the medical eligibility criteria. So for example, if you got a 16-year-old who needs a COC, for example, then age itself is not a barrier. Now, if she is overweight, again, it's only WHO2. So WHO2 means that you can start without much of a problem, unless she is grossly overweight with BMI more than 35, for example. Then there is some differences in the recommendation between the WHO MEC and in the UK MEC. The UK MEC is a bit more cautious that those who are extremely overweight, they do not want to start a combined, but the WHO still maintain that the risk of starting is lower than not starting. And so, of course, then WHO weight is not actually a problem. So you can start in adolescent. That's not an issue. Yeah.
Right. So in view of the time and there's so many questions, I'll ask the last and final question, especially in terms of oral contraception in perimenopausal women. When can they stop taking to be safe from getting pregnant? Right.
Okay. Two guidelines. One is, of course, if you talk about oral contraception, and again, two groups, COC and POP. If you talk about COC, you cannot take more than 50 years old. Once you're above 50 years old, then your WHO MEC become 3, WHO 3. That means that the risk is more than the benefit. So you have to change to a POP if it's 50 years old and above, right? So that's one guideline. The second is, of course, if they're on POP or on any contraception, when can they stop? 51, 52, 53, 54? The answer is you can stop as long as she is menopause. How do I know she is menopause? Because she's been using implant or POP and she got no period, right? Of course, we can then do the serum FSH. And if it's more than 30 twice apart, 6 weeks, we can stop. Or, of course, you can tell her to take until 55 years old. At 55 years old, in theory, no one is supposed to be able to get pregnant already unless they change the IC, whatever. Yeah. So at 55, we can safely stop all contraception.
Right. Thank you, Dr. John Teo. I mean, given the very questions that we have, thank you very much for your time and your insights. These are very well answered questions. Now we have more of the next segment. So thank you, Dr. John.